Hello everyone, welcome to this lecture on enteric fever, that is typhoid and paratyphoid, and today we are going to discuss the management of this very important cause of fever. So then what knowledge do we have? We now know that this is Salmonella and it is gram-negative flagellated rod, and the Salmonella enterica serotypes typhi and paratyphi ABC causes these diseases. And the fever in this is in the step ladder fashion, as well as other clinical features are such as malaise, headache, drowsiness, myalgia, constipation, diarrhea and abdominal pain are present in the patient, as well as rose red spots are there, as well as splenomegaly may also present, and ulcerated Peyer's patches are there. And if these ulcerated Peyer's patches, such as here we can see one, if these are not treated well, then they may cause hemorrhage and may even perforate, as well as there may be the chronic carriers in the gallbladder, and they pass bacteria intermittently in the stool. And the investigations include maybe leukopenia may present, as well as blood culture and the Vidal test, and the 1 ratio 160 and above is considered as positive. So all this knowledge we have. Let's continue. So then today we are going to see the various specific measures in the treatment of the typhoid, and the treatment of the carriers, and how can we prevent from happening this disease to us, and we will see the case study too, first in the starting and one in the end of this lecture. So this is a case study. 18-year-old female patient was admitted with a fever and fatigue, and she also had headache, weakness, palpitation, abdominal pain and diarrhea a week later. And the patient was confused, and she was admitted, and there was intestinal hemorrhage and hepatic involvement was there, and Salmonella typhi was grown in the blood culture. Patient was discharged with full recovery after the ciprofloxacin treatment in addition to the electrolyte replacement. So as you can see this case study, you are maybe understanding that it is a case of typhoid fever, but we will understand this in this lecture with better knowledge. So then what are the specific measures that we use to cure this disease? So the agents of choice for the treatment are fluoroquinolones. So the fluoroquinolones or FQs are the most commonly used agents. They are the drug of choice that are used for the treatment of this disease. Alternatives are ceftriaxone and azithromycin. All these all these three drugs are very important for the treatment of the typhoid. We will see them one by one. So then let's start with the fluoroquinolones. So the fluoroquinolones or the FQs, they end with the suffix floxacin. Okay, so the examples, most commonly used examples are ofloxacin, then norfloxacin, ciprofloxacin and levofloxacin. Okay, so these are the most commonly used examples of the fluoroquinolones antimicrobial agents that are used in the daily practice. How do they act? What is their mechanism of action? Well, they are broad antimicrobial activity. They have this broad antimicrobial activity, and they target bacterial DNA gyrase and topoisomerase. Okay, so these two enzymes So the fluoxetine, the fluoroquinolones inhibit these two enzymes. DNA gyrase is present in the gram-negative bacteria while the topoisomerase 4 in the gram-positive bacteria. Okay, so the fluoroquinolones inhibit these two enzymes. Okay, in the gram-positive bacteria and gram-negative bacteria. So the drugs we use for the treatment of the typhoid is ciprofloxacin, and the dosage is 750 mg orally 2 times a day. Okay, or we can use levofloxacin 500 mg orally once daily. Okay, so these two drugs, these two fluoroquinolones are used for the treatment of typhoid. Ciprofloxacin 750 mg and levofloxacin 500 mg. Ciprofloxacin 2 times a day while levofloxacin 1 time a day. And the duration is 5 to 7 days for uncomplicated enteric fever, while 10 to 14 days just double of these. Okay, 5 to 10, 7 to 14. Okay, so the 10 to 14 days for severe infection. Okay, so 5 to 7 for uncomplicated enteric fever, while 10 to 14 days for severe infection. Very important to learn. Okay. So if you are treating a patient with ciprofloxacin or levofloxacin, you must have the idea of various adverse effects which the patient may experience. So the adverse effects are most commonly in the GI, such as mild nausea or vomiting and abdominal discomfort. Okay, while in the neurologic adverse effects, there may be mild headaches or the dizziness or insomnia, anxiety. All these adverse effects are very important to know, as well as if the patient have a history of epilepsy, means the patient suffers from seizures, then they are at higher risk for fluoroquinolone induced convulsions. So if you have some patients, such as you have a female patient and she have epilepsy, then you will have to prescribe fluoroquinolone very cautiously. Okay. As well as the most common and most important adverse effects which you all should know are the musculoskeletal adverse effects due to the fluoroquinolones, and they are arthralgias and joint pain, as well as increased risk of cartilage damage. Okay, these two are very important to know: arthralgias and joint pain, and there is an increased risk of cartilage damage, and both of these are especially common in children. So the children are at increased risk of these adverse effects. So the ciprofloxacin or levofloxacin or any other fluoroquinolone should be prescribed very cautiously in children. As well as other musculoskeletal adverse effects includes tendon rupture or tendinitis, usually in the Achilles tendon. Okay, so it is a serious adverse effect and it is especially in those more than 60 years old. So the tendon rupture or tendinitis is more common in old age patients, especially those old age patients who are using corticosteroids. But for now, just learn arthralgias and joint pain and increased risk of cartilage damage in children, tendon rupture or tendinitis in old age patients. Other important adverse effects include QT interval prolongation, which leads to the torsades de pointes. Okay, so it is also a one very important adverse effect which you all should know, which can be asked in your entrance examinations or university examinations. You should know this. And the highest risk is with the moxifloxacin, one more fluoroquinolone, as well as gemifloxacin levofloxacin and ofloxacin have lower risk, while the ciprofloxacin have the lowest risk of QT interval prolongation. As well as these fluoroquinolones can show rashes, including photosensitivity reactions. So the patient should use sunscreen if the patient is going into the daylight. Okay, so all these adverse effects are very important to know of fluoroquinolones. Now we will see the cephalosporins. Cephalosporins are beta-lactam antibiotics. Okay, and two cephalosporins which are used in the typhoid treatment are ceftriaxone and cefotaxime. Okay, so these two cephalosporins are useful alternatives. Okay, they inhibit bacterial cell wall synthesis just like all beta-lactam antibiotics such as penicillins. Okay, so they inhibit bacterial cell wall synthesis, and ceftriaxone is given IV and the dosage is 2 gram 2 times a day for 2 days. Okay, 2 gram 2 times a day for 2 days, and it is followed by 2 gram per day till 2 days after fever subsides. Okay, so if the patient have fever today, then you will give 2 gram 2 times a day for 2 days, and then you will continue with such as 1 gram 2 times a day, and you will continue till the fever stops. And when the fever stops, then also you will continue for next 2 days for 1 gram BD. Okay, so that is the dose of ceftriaxone. It is a very important alternative and it is widely used also. As well as if the patient is a child or some pregnant woman, then ceftriaxone is a safer alternative than fluoroquinolones. Okay, but nowadays these cephalosporins also have a slightly increased treatment failure rate, so you have to use them cautiously. So, what are the adverse effects of cephalosporins? One most important one is the hypersensitivity reactions. Just like penicillins, they also show hypersensitivity reactions, which includes anaphylaxis, bronchospasm, and urticaria, which are immediate reactions, as well as there may be maculopapular rashes, usually after several days of therapy, which may or may not be accompanied by fever and eosinophilia. As well as, of course, it is antibiotic and a beta-lactam as well, so the diarrhea may happen. And one more important thing to know is that ceftriaxone displaces bilirubin from the plasma protein serum albumin due to high binding affinity of ceftriaxone. So if you are using the ceftriaxone in a neonate, then there are higher chances of jaundice due to the raised bilirubin in the blood of the neonates. So in this case, you can use cefotaxime. Okay, so all these things are important to know. Next, one more very important alternative is azithromycin, which is used nowadays more oftenly than ciprofloxacin or ceftriaxone. Okay, so the macrolide antibiotics includes erythromycin, clarithromycin, of course azithromycin. Okay, so all these are macrolide antibiotics. They are bacteriostatic agents, while the fluoroquinolones and the cephalosporins are bactericidal. They kill the bacteria, while macrolide antibiotics are bacteriostatic agents, so they stop the division of the bacteria. So they inhibit the growth of the bacteria by inhibiting the protein synthesis. Okay, how do they do this? They bind reversibly to the 50S ribosomal subunit of all the sensitive bacteria. Okay, so they bind with the 50S ribosomal subunit and they inhibit the protein synthesis. That's how they inhibit the bacterial growth. Okay, so we can use azithromycin in this typhoid patient and inhibit the growth of the salmonella, and the dosage is 500 mg once a day, and we use it for 14 days. Okay, at some places 7 days is written, at some places 14 days is written. Okay, but in a standard book I found 14 days. Okay, so the azithromycin 500 mg once a day for 14 days, a very important alternative. As well as one more thing I would like to add, that nowadays there are extensively drug resistant typhoid bacteria. So in the Pakistan since 2016 there are a lot of extensive drug resistant typhoid patients, and azithromycin is the only currently reliable oral therapy in Pakistan. So in India too we use azithromycin a lot nowadays. So what are the adverse effects? It will cause GI distress, of course, as well as, just like fluoroquinolones, it is also a one important cause of QT prolongation with ventricular tachycardia. Okay, as well as macrolides can cause hepatotoxicity and allergic reactions too. Okay. Now we will see the treatment of carriers. Now if we want to effectively eradicate the carrier state, then ciprofloxacin can be given 750 mg orally 2 times a day for 4 weeks. Okay, so for 4 weeks we will give ciprofloxacin. If still there are bacteria, means the antimicrobial therapy fails, then we use cholecystectomy. Okay, so it can be used. Now how to prevent? Of course, first most important thing is sanitation and the living conditions. They should be improved, as well as there should be adequate waste disposal. Okay, and the carriers cannot work as food handlers. Okay, because if they are carriers then they may contaminate the food. And one more preventive method is typhoid vaccine. We will see this. So the typhoid vaccine, as there are increase in the number of drug resistant strains of Salmonella typhi, the treatment is very challenging nowadays. So there are two vaccines that are available which we may use for to prevent the infection. First is the inactivated or killed typhoid vaccine, which is injectable, and a very easier one is the oral one. It is a live typhoid vaccine. Both of them have similar efficacies, but oral vaccine causes fewer side effects, so it is a better alternative than injectable one. So this is the bacterial polysaccharide vaccine. This is the inactivated one. It includes the typhoid V polysaccharide vaccine. Okay. Other bacterial polysaccharide vaccines are such as meningococcal polysaccharide and pneumococcal vaccine polyvalent one. Okay, so all these are examples of the bacterial polysaccharide inactivated vaccines, and one is our own typhoid VI polysaccharide vaccine, which we may use to prevent the typhoid. Okay. Now we will see the live attenuated vaccine. This is the typhoid, oral typhoid vaccine. Okay, just like other examples such as MMR or OPV or rotavirus or BCG or the varicella Zoster virus vaccine, all these are live attenuated vaccines. I have shown them to just so that you can revise. Okay, one is the typhoid oral typhoid vaccine. Okay, thank you. If you love the lecture, then please take membership of this Patreon channel. This is a case study. Please read this. You will get some more knowledge. So what knowledge we gain today? Now we know that there are specific measures such as ciprofloxacin and levofloxacin, ceftriaxone and azithromycin. Most commonly used agents are these: ciprofloxacin 700 mg BD, levofloxacin it is once a day, ceftriaxone it is 2 gram for twice for 2 days and followed by 2 gram per day till 2 days after fever subsides, and azithromycin 500 mg orally, it is once a day for 14 days. And for the treatment of carriers, we use the ciprofloxacin for 4 weeks. And there are the typhoid vaccines such as inactivated or kill typhoid vaccine, which is injectable, and the live typhoid vaccine, which is oral vaccine. Okay, these are the references. Thanks a lot.